Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this overcoming situation of COVID-19. Dear viewers, today our topic is deformities around knee corrected by Ilizarov technique. And the speaker is the one and only the legendary Ilizarov surgeon. We called him the magical Ilizarov surgeon, that is Professor Mofakkarul Barisar, the pioneer Ilizarov surgeon of Bangladesh. I would like to request Professor Mofakkarul Barisar to join with us.
Yes, good afternoon, everyone. Thank you for introducing me.
Thank you, sir. Thank you for joining with us. Dear viewers, we have three learned academic experts with us. One of them is Professor Omar sir from Kurdistan, Iraq. I would like to request Professor Omar sir to join with us.
Friday for everyone. Thank you so much.
Thank you very much, sir, for joining with us. And dear viewers, we have another enthusiastic Elizarov surgeon from Patna, India. And he is the Dr. Shamsul Huda sir from Patna, India. I would like to request Dr. Shamsul Huda sir to join with us.
Very good afternoon, Dr. Anil. Thank you.
Good afternoon. Thank you very much for joining with us. Dear viewers, we have another academic expert from Kurgan, Russia. That is our Novikov sir. Hope he will join in the coming part of our program. And now I would like to request to continue our program. And today our topic is deformities around knee correction by Ilizarov technique. But how? And that will be discussed today by our honorable speaker, Professor Mofakkarul Barisar. Now, I would like to request Professor Mofakkarul Barisar to share his screen with us. Sir, would you please share your screen with us, sir, please?
Okay. Thank you, Tanveer. My dear friend, Professor Umar, Shamsuluddha, Professor Novikov, and dear viewers. And today, I'm going to talk on my topic, which is very important, especially the knee, the deformities that we are facing every day in our day-to-day life, that may be congenital, post-traumatic, and whatever you can say. So what do you mean? A deviation from normality. Whenever you are getting any kind of deformity, you'll obviously see the contracture. That is means deformity of a joint due to soft tissues. And what is the definition of contraction? Limitation of movement in a definite direction is called contraction. You can get flexion contracture or extension contracture. When you talk regarding the bony deformity, you'll see angulation. That means ad axin in Latin, translation ad latus, rotation ad peripherum, and length, that is called ad longitudinally. Or you will get all these four types of deformities with other combination. Now, before doing that, we must know the angulation is a rotation around a horizontal axis. You can see here, and rotation is an angulation around the vertical axis. These are the two definitions. You must keep it in your mind. Before doing any kind of surgery in any joint of the inferior extremity, you must know the mechanical axis, straight line that connects the joint centers, proximal and distal. The orthopedic surgeons, those who are doing deformity corrections, they know it very nicely. And for young budding orthopedic surgeons, it is very important to know at the same time mechanical and anatomical axis is the mid diaphyseal line of the bone segment. Just I'm repeating the simple things. Tibiofemoral angle, it is the angle between the anatomical and mechanical axis of the femur. You can see here, and this is the axis of tibia. Also, you know, mechanical axis and anatomical axis. Mechanical, that line from center of the proximal to be a center of the distal tibia. Mid diaphyseal in both axes almost the same. And these are the some angles. You must keep it in your mind. That's why I'm going to talk on the joint orientation angle. It refers to the position or angular surface relatives to limb axis. And it is the angle between the joint lines and the limb axis. these are the four angles. This is these two is 87. To keep it in mind, this one is lateral distal femoral angle and MPT medial proximal tibial angle 87, 87. And JLCA, whenever we are doing any kind of deformity correction in the knee, joint line convergent angle 0 to 2 degree. These are the important angles. You must keep it in your mind when you are going for any kind of deformity correction in the knee. And to keep it in your mind, these four angles. This is, LPFA 90, this is 87, this is 87, and this is LDTA 90. So 90, 90, 87, 87. If you know all these four angles, then you will be able to correct the deformity around the knee or hip or in the ankle. Now, understanding deformity correction, when we are talking about the deformity correction, we must remember is there is a deformity or in this bone is deformed, source of deformity, it is congenital or acquired, level of the deformity, in which level you are getting the deformity, and which plane you are getting the deformity, and what about the angle, that means magnitude of the deformity, and where you will do the osteotomy, and which kind of osteotomy you are going to do, acute versus or gradual correction, or which method, either you are using internal or external, or you are using Ilizarov or not. And it's important thing is never operate on the wrong bone. So these are the important things that you should have to know before doing any kind of deformity correction. Now, outline, if you think about the deformity analysis, I am okay, you are okay, that means everything is normal alignment. I am okay, but you're banned. How to measure and define deformity. Intelligent games, deformity options for correction. And how will correct? When you are going for treatment, come lie on my couch. That means whenever you're doing any kind of deformity correction, important consideration to deformity correction, arthroplastics, and fracture management. Now, dear friend, this is a C. You can see the bowing of the femur, bowing of the tibia from front side and from the back side. Is the limb normal? If the mechanical axis in its normal position, the limb is aligned. If there is mechanical axis deviation more than normal, that is 8 mm medial to the center of the joint line, limbs is not aligned. And these are the simple things you also know regarding the varus deformity and the valgus deformity. Lateral mechanical axis deviation denotes valgus deformity, and medial mechanical axis deviation denotes varus deformity. Here you can see the valgus, and here is the varus. So mechanical axis deviation 8 plus minus 7 mm from medial side. Now question number 2, if the limb is not aligned, why is the malalignment? Whenever you are looking that your bone is not in normal position, then you must find out the malalignment where. And source of deformity. These are the very important things that you must keep it in your mind. I told you this MPTA is 87, this one is 87. Now see the difference, 94 minus 87, how much is differ from this to that. And here is C, this is 94, MPTA 82, means here is less, 87 is the normal. So these are the source that you have to know where is your malalignment. Now you can see here, MPTA here is 82. That means you must correct here. You must get it 87. JLC is 0 to 2 degree. Here JLC is 7 degree. Here this is normal. And here 82. That means you are getting less. So you should have to correct here MPTA, medial proximal tibial angle. Again, malalignment source you can see here. Femur 87. Okay. But here 94 not okay. Here is 87. Here is 82 not okay. You can see the JLCH almost the same. Here is 94. Here is 82. both the angles are not in normal position. Same 87 and 82. Here is the normal, here is not normal, and JLCA is 7 degree. So before embarking any kind of deformity correction, these are the important angles that you should have to think about all these angles. Now, rotational deformity of the tibia. Whenever you are getting any tibial torsion, you can see the patella forward, and rotational deformity of the femur from this side or that side, you can see. And how to correct the deformity, we have to identify three things. And those who are doing all the time with deformity correction, you must know the level of the cora, true apex of the deformity, and level of the hinge, where you are going to put the hinge, and in which level you are going to do the osteotomy. Now, center of rotation of angulation is the level of the deformity. Center of angulation of rotation means center of rotation of the angulation cora. That is the true apex of the deformity. Now, if you think that your normal femur is normal and varus tibia, see here, very simple, draw the lines, and this is your meeting point, true apex of the deformity. This is the true apex of the deformity. Now, Ilizarov fixator has broadly two components: hinge, by which we correct the deformity; rings and pins, by which we fix the Ilizarov fixator to the bone. Hinge is the most important component of the Ilizarov apparatus, and surgeon has complete control over the level of the hinge. So, Professor Ilizarov was always saying, loved to say, no surgery is justified to do any reconstructive surgery by Ilizarov technique unless he has got the confident idea regarding the technique and the apparatus. And Professor Ilizarov was always fond of saying, you give me the hinge, we will correct all the deformities. So here, friend, speed of correction of the hinges, rule of triangles. See, if you see your bone is like that, level of the hinge, see here, and position of the ring, you see how the placement of the ring, and here you can see AB by AC, AB by AC equal to DE by FG, 3:1. That is the rule of triangles. And you are getting, when you will do the osteotomy here, you are getting this kind of opening weights, bone, regenerate bone. Again, normal femur, varus tibia. See problem in the tibia, even with normal eyes, you can see this is the center of the rotation of angulation. That means true apex of the deformity, metafacial deformity. And now I'd like to share my cases. There are a lot of cases, but during this short time, you cannot put all these things. Look at this deformity. Genu Valgum, post-traumatic, 14 years old boy. Just look, dear friends, the puckering of the skin, back side, look, from the side, back side, front view, back side, and you can see the tilting. And now you can see here, this is the puckering of the skin, bed scar, and 10 centimeter LLD. If you draw your angles here, you'll be able to understand where is the malalignment and how much level of deformity, magnitude of deformity, and which kind of deformity you are getting here and what you'll be able to do. Dear friends, now you can see here, I have done the osteotomy here, placement of the hinge, and osteotomy in the tibia with olive, gradual correction, osteotomy in the fibula, and then you can see here gradual correction, and now see the anterospheric spine, draw a line, and this is the full correction. And after removal of the apparatus, now you will be able to understand, see before correction, this was the angle shortening, and after correction, you can see the placement, long axis, JLCA, and level of the ankle. Now, this is before, this is after. This is before, front view, back view. Now you can see no puckering of the skin after correction only after 7 months. So Ilizarov gives you the good idea how to correct this kind of deformity, which is related to the knee as well as the ankle, and of course, the relation goes up to the femur, up to the hip. Now, see, difficult case, severely deformed bilateral Genu Valgum with patellar tracking. If you draw the lines, where is the patella you see here? And this is the front view, back view, this is the X-ray, radiogram, just you can easily identify where is the deformity. Now, patient with this undergoing physiotherapy, rehabilitation, of course, sometimes it goes very difficult for the patient to go for that. And here is the opening wedge you can see here. Now, before, and it took 11 months for full correction. And see the height, see the backside, see the front, axis. You will not be able to understand the before surgery how his condition was. And from that situation to this situation, a little bit deformity exists, but that does not make any hamper. You can see here, see, it gives a very good satisfaction to the doctor and the relatives of the patient. And this boy, I have the follow-up for near about 11 years. Now, fantastically, he's leading his life. Now, you can see here, juxta-articular deformity. Look at this friend. See the ankle, 180 degree almost. If you look from this side, you will not be able to understand where is the deformity and how much deformity here. Backside, you see, draw a line. Now you can see the X-ray. Depressed patella of the medial plateau, tibial plateau, and she's from Myanmar. Myanmar, she came to my place to get treatment, and look at the knee joint here, and look at this. I have done the lateral opening wedge osteotomy first, and you just look here, depressed patella, plateau, tibial plateau medial, and then just look, dear friend, here I have just opening wedge, and your lower end of the condyle of the femur is almost the same line, but this is depressed still. And now she was walking like that. This is the X-ray view during treatment. And then it's very difficult. Beautiful lady, girl, not lady, I must say. And now this is, you can see here, depressed patella, tibial plateau, medial. And then I have done the osteotomy here. Look at this. What kind of osteotomy I have done gradually. And I have elevated that one. And this is, you know, full correction you can see from this side and that side. Only one problem is that the 100% full flexion was not possible. So this is a case, post-burn knee dislocation, deformity, FFD, equinus, 10 years old boy. See, embodied left arm, the post-burn case, neglected, came to a place with this knee dislocation. See back and front, lower end of the femur. And then after 3 months, he came to my place after the incident. Then gradually, only with biocompatible thin olive wires and wires, placement of the hinges with two rings up, and this is the final almost corrected position of the leg. Now you can see here from that to that situation. So before and after 3 or 4 months, probably I remember still he could walk without any support. Still, he doesn't have right. This was also embodied elsewhere, not in the center. Now let us see another case. This is bilateral Genu Valgum. Again related with the knee. Where is the patella? You can see here. Draw the lines, see the ankle and the foot, see the ankle and the foot. And if you look at the radiographs before surgery, sometimes it is difficult to understand how to do the surgery. Opening wedge, here, you see opening wedge, only with the wires. I have not put any chance. See, you can see olive and the wires. And he is a college teacher. And during treatment, this is the opening wedge. Good regenerated bone is going on. And look at the JLCA, almost corrected this one. And then see, after 9 months follow-up, and before, look at this distance of the bimillimeter. See here, see the foot and the toes, see the knee and the patella. Just after correction, almost corrected. If you draw a line, axis of the axis, center of the hip, knee and ankle, center of the hip, knee and ankle. And before that, she was walking like that. You see, very difficult for the patient with this situation. 32, 33 years old, difficult to manage and difficult to treat. And ultimately, if you look at this, it's very good correction of the knee, ankle, and of course the axis is normal. Now, post-traumatic right femur of the knee, a knee injury with deformity and 7 centimeter shortening. Young girl, see, look at this. She's a daughter of a army personnel. It was like that. See here. See the patella. And then after 1 year, before treatment, and this is after 1 year treatment. And since she was running at the time 11 years, she had a little bit problem, then came to my place again. Then I treated again with Ilizarov fixator. And this is after 3 years follow-up. You can see from this situation to that situation. Now she's 15 years. She's okay now. And this is the case, the ricket, bilateral bowing femur, and bowing tibia. So these are the cases that are sometimes very difficult to treat. See how she was walking, fully O, fully O, fully O. This is the view of, see, O type. Bones quality are not good. Then gradually you can do the 2-level osteotomy in the tibia and in the femur also. See, after 3 months, this is after 5 months. 5 months. This is before. And see, pre-operative MPTA was 95 degree, post-operative MPTA 87.2 degree. Here, radiologic result. And after that, this is, you can draw a line, 2-level osteotomy here you can do, and at the same time in the fibula also. So this is the after 8 months follow-up. Now you can see a pterygium of AMT, again related with the knee deformities. Pterygium, soft tissue here is contracted. Pterygium right knee, gross LLD, 5 centimeter in femur, 7 centimeter in tibia. And close-up view, patient is in sitting position before treatment. See what I've done, soft tissue release, and then gradual destruction by Ilizarov, placement of the hinges you can see, and then gradual correction of the right knee flexion with Ilizarov apparatus, almost corrected, clinical appearance, just you can see here, and this is a back view of the right knee. Now, this is the case, the FFB of right knee, daily activities were limited, movement was only by jumping or crawling, and LLD was 12 centimeter. We corrected the deformity using gradual control coordinated with the Ilizarov fixator for 110 days, as well as lengthening of the femur and tibia was done. When I was in Nichol, then see, he was working like that, and this is the after full treatment. Now he's fantastically living his very daily activities and good life with full correction of the deformity. And now another case, see, related to the knee. Look at this, 45-degree varus, 7 centimeter LLD. Look at this here, and of a 23 years old girl with beautiful face. Now, how we can correct? Just before here is the C, here is the nonlinear, here is the deformity. Look at the JLCA, look at the lateral view and deformity of the fibula. So you should have to address all these things simultaneously. You can do that. What I have done, see, corrected here, one ring, one ring, one ring, one ring, and placement of the hinges here. And you go for gradual correction. Now you can see, dear friends, 7 centimeter LLD and front view, a little bit here, no, and from the back side, you can see no deformity. And this is the case which was treated elsewhere by, lower end of the femur, fibula graft, you will see with this implant, and she came to my place, 20 degree, here is the problem, and he was working policeman, sub-inspector of the police, 5 centimeter LLD, and then how you can solve these kind of difficult situations. See, I have removed the implant, put Ilizarov apparatus, again with biocompatible thin wires and olive wires. And then patient is walking nicely with the Ilizarov fixator. After 6 months with his stiff knee, this is the healing process. The knee is stiff. Here is JLCA, a little bit, see here. This is the depressed joint space is reduced, right side. And then I have done the second operation, that is Jude's quadriceps plasty. After 11 months follow-up, you can see how he's working with this. This is before, this is after 11 months follow-up. And this is after Jude's quadriceps plasty, 5-step surgery was done. Nowadays, I'm doing modified Jude's quadriceps plasty with 3-step surgery. And this is after treatment, only after 4 months. And another one you can see here, whereas deformity of left upper tibia with 5 centimeter shortening. Again, you draw the angle, see here, front side, back side, and see here, the fibula and the tibia, draw the angles. This is the magnitude, and how to correct that one, see the opening wedge, placement of the hinges, and gradually you just distract and go for correction. And this is after 5 months follow-up. Look at this, from this situation to that situation. And another case, see the 18 years old boy, look at this, depressed medial plateau, JLCA is distorted. Now, young chap, from front view, back view, this is before surgery, and then I have put the one ring here, done the medial wedge, opening wedge osteotomy here, gradual distraction with the placement of the hinges. Now you can see sequentially how deformity correction is going on. And after removal of the apparatus, you can see here the joint space, long axis, and the lateral view, and now after 8 months, and this is after 2 years follow-up. These are 2 years follow-up. And now from this situation to these situations, after 2 years follow-up, you can see fully fantastically corrected, gradual opening wedge, and range of movement is 100% okay, no deformity, no any kind of restricted movement in the knee. And see, dear friends, almost going to finish. Look at this 3 years old gap non-union. This is the segmental fracture of the fibula, proximal fibula. This is the part of the fibula. Look at these 3 years old non-union upper tibia with bad scar. Look at the bad scar. Segmental fracture of the fibula, gross displacement of a 30 years old male. And this is a challenging case. If you see only the X-ray, you will not be able to understand what was the problem there. Then I have opened up, here little bit opened up. I have aligned the whole fibula and put the K-wire, and then you can see one ring here, and 2 rings below. And look at this. Now, this is the fibula. This is another fibula. This is segmental fibula. Now you see I have corrected the whole fibula just like before, and see the squatting position of the patient. And this is the wire technique. The condition of the skin is also good. And finally, one case of DCT. I'd like to share my experience. Look at this, the lateral part of the tibia, giant cell tumor of a young girl. What I have done, curettage and segmental bone transport with olive wires. See, I have transported. This is the lateral view. This is the medial view. Now you can see here, this is previous one. This is after correction of the lateral side of the tibia. And this is after 1 year. Look at this beautiful girl, 17 years. No recurrence rate, no recurrence here. Now see, fully corrected with segmental bone transport after doing curettage. So I always love to tell the biological principles of Ilizarov gives gradual distraction, which has revolutionized the management of limb deformities. You can go for this LLD, bony and joint deformities, any kinds, soft tissue contractures. If you have a very big bone loss, you can transport the bone, and you can have a very good bone, regenerated bone, any kind of delayed and non-unions. And of course, Ilizarov, if you follow the original Russian principles, Kurgan pattern principles, you can control the infection. And nowadays, transverse distraction of TTT, I am doing a lot of cases, dear friends, for getting new vascularization. And this is GCT, my publication. Why Ilizarov? All the time I'm telling this. See, you can hear. Ilizarov, feel any defect in life of bone. When you were hopeless in orthopedic treatment, think to Ilizarov. Extended the quality of life by Ilizarov lengthening. When all lights are off, the light of Ilizarov is on. And ILIZ angiogenesis, reliable, opportunity, overwhelming, versatile, and victory. And the end of disability by Ilizarov, bright future in disability by Ilizarov. Dear friend, this is the message. Always I tell, whatever I'm showing, I have got the evidence. And I am talking, whatever I talk on science. And of course, the surgical skill of the surgeon. And this is love to tell all the time, the biology, Ilizarov is always biological and mechanical. And in my country, we are doing a lot of cases by advocating biological and cost-effective technique that is Ilizarov and Globe might appreciate. Thank you so much for your kind attention.
Thank you very much, sir, for your magical presentation. It was just like a movie. When it finished, we cannot understand. And that was an excellent presentation. Now, I'd like to request Professor Omar sir to say something regarding the presentation. Professor Omar sir, please.
Okay, thank you so much. Very nice presentation. Congratulate him. I would like to tell us a little bit more about giant cell tumor, the procedure which was done for that case with giant cell tumor. Otherwise, it's fantastic presentation. Thank you so much.
Thank you very much, sir. Sir, I have a little question. Do you ever face any neurological problem or any jeopardized vascularity in case of deformity correction? Is there any chance of that, sir?
Yes, you have chance. But you know, in my early age, I faced when I was in assistant professor in Mymensingh Medical College, I faced one vascular problem in the lower end of the femur. Otherwise, since today, starting from my early age to this stage, I'm not facing any kind of difficult problems with the vessels and the nerves. And if you are cautious, if you are, meticulously intelligent follow-up, for the time being, you may face problem, but Ilizarov gives you the chance to overcome all these problems. If you face any problem, you can, with the wires, you can just remove your wire and you can do the electrostimulation, you can solve the problems. Otherwise, till today, I have not faced any kinds of difficult problems with the Ilizarov apparatus. And technique, if you properly do that, you will be able to overcome all these problems. But sometimes it happens if illiterate patient, then you should have to counsel. So before surgery, doing Ilizarov surgery, I am talking with the patients before surgery, and after the surgery, I just instruct, I give them a book. I have a small book written in Bengali in our language so that everybody can understand how to lead a life with Ilizarov apparatus. I give the book to them. I supply the cover of the Ilizarov apparatus cover and book, and at the same time, I tell them to read this book. Sometimes I ask the questions to the relatives of the patient or the patient. Have you read this book? How to live a life with Ilizarov apparatus during your 5 or 6 or 2 or 3 months or even 1 year follow-up. That is a very good book that I've written in Bengali, and you can see this book in the internet also. And I have a publication of how to lead your life with Ilizarov apparatus. You can see it in Medcrave, Orthopedic Journal, and Rheumatology. So doing surgery with Ilizarov, you must talk with the patient frankly. I never tell any kind of negative to the patient of Ilizarov apparatus. Never.
Okay, sir.
Okay,
Yes.
thank you.
Yes. Yeah, thank you, sir. Thank you very much. Now, I would like to request Dr. Shamsul Huda sir to share his knowledge, or if you have any question regarding the presentation.
Thank you, sir. Thanks for wonderful cases, sir. Learned a lot from these cases. We have been doing, sir, lots of deformity cases. Here, I have two questions from you, sir. In aged patients with osteoarthritis and knee varus, we do STO and correction with Ilizarov. So for you, what is the level of ostomy? It is the supratuberosity or infratuberosity? Number one, sir. And what is the benefit of pain with arthritis?
This is very good question. You can both level. You can do both level. You just draw the angle, put your deformity, and you do the osteotomy from the medial side and go up to the lateral side of the marking of the head of the fibula. Don't break the last cortex. Gradually, you can do 10 to 20, 50 degree, and by this time, gradually you can do the deformity correction. And Ilizarov technique, you must do everything gradually. And regarding the STO, simple STO, grade 1, 2, 3, you can go STO. And at the same time, 2 or 3 lectures before, I told regarding the microfracture, that is tunnelization. of the patella, of the lower end of the femur from the medial side and lateral side up to the subchondral region, and in the tibia also. You can combine both this. And when you are doing this microfracture, that means tunnelization, you are increasing circulation in the whole joint. And a patient will tell you, the doctor, I'm feeling very good. You know, even the osteoarthritis patient, our young generations, whenever patient comes to you, they are putting all the time intraarticular injection, and it gives a dramatic result, pain relief. Again, 3 or 4 months, 6 months, patient will come to you. So better to go only for osteoarthritis. There are two classifications: Kellegren, Lawrence classification, X-ray, or Ahalbach classification. 4 types of this classification. 2 and 3, you can go for joint distraction for 10 days in the knee, putting the 2 rings up, 2 rings below, and microfracture, and go for distraction for 10 days. You will get a very good result. This is established. You can see not only Russian technique, in Western world they are also doing HD, articulated hinge distraction by Ilizarov. That is your answer of the question. So far I have given you the answer. Thank you.
Thanks, sir. Thanks a lot, sir. Just extending the question, sir. After doing the joint distraction and subchondral microfracture, do we see some improvement in the articular damage, the subchondral defects, or the cartilage damage? Is there any benefit in that also?
This is just like when you are giving distraction, you will get a regenerate bone in the cartilage, just like a Partridge disease. In Partridge disease, you are doing tunnelization, keeping the bundle of wires in the head and neck, and you are giving the distraction. That distraction increases synovial circulation. And of course, not 100%, a little bit regenerate of degenerative bone is going on. That is the beauty of Ilizarov. At least you can save the limb. And I'm doing all the, you see, whenever patient comes to my place with knee osteoarthritis, with varus deformity, I do the osteotomy and then this tunnelization. No deformity, then you can go for distraction. Ask your patient, nothing to do with any, no stitches, nothing. Only distract for 10 days. Tell your patient to remove after one and a half month or 2 months. Patient will be able to walk. That is good result.
Wonderful, sir.
Distraction of the
Thank you,
joint.
sir. I have another question, sir. So in knee flexion deformities with limb shortening, when you do the flexion correction and the lengthening also, do we get further exaggeration of the knee flexion because of tendon stretching, sir? After we do the correction and lengthening, yeah.
Listen.
Does the flexion get exaggerated? Yes, sir.
Yes, I got your question. Knee flexion deformity in AMC case, remember now I am shortening of the lower limb one time. Shortening of the lower femur or upper. So it is better to go for shortening of the lower femur. Then you will get full correction. You don't need to open. I have shown you the one case, soft tissue release and gradual distraction. If you do the part of the bone, remove, and you can put plate or screws, better to go for Ilizarov. No infection, nothing. Then you can correct your deformity full. Then again, for shortening that, you can go for lengthening. You understand?
When we do the lengthening, does the flexion, does the contracture recurs or not, sir? After
no. Once you have done this, no, you will not get.
Right, sir.
Okay.
One last question, sir. Suppose in knee varus deformity due to Blount's or some other where growth place has been affected, and we have corrected the deformity. With growing age, does it recur, sir? Once on the medial side.
Yes, yet if you do the varus deformity in Blount's disease in early age, 2, 3, or 4, at that age, if you do the surgery, you must tell the parents it may recur. And at the age of 10, 12, you'll see the recurrence is going on. You must tell to the patient, counsel to the patient. Yes, you'll get it. Yes. So counseling is very important. You may recur second time surgery. You tell them and everything will be okay. If you don't tell them, they will catch you again. Sir, you have done the surgery. Why recurrence? These are the teachings.
Thank you, sir. Thank you, sir.
Okay.
Thanks a lot, sir.
Thank you.
Thank you. Thank you very much, sir, for excellent discussion. And thank you, Dr. Shamsulida, sir, for nice questions. Dear viewers, today is our
Very, very good
49th
question.
episode of Orthopedic Solution Academy, and hope we will meet you in the coming Friday with 50th episode of our program. And I would like to thank Rajtv for helping us to arrange this type of academic program, and definitely Rajtv Pharmaceuticals Bangladesh Limited for sponsoring our program. I'm Dr. Mohammad Tanvir Ashraf saying bye-bye today. Hope we'll connect you in the coming Friday with another magical topic. Till then, bye-bye.
You are watching Rajtv, Jagorone, Bangladesh.